And good evening, everyone. And welcome to this episode of the Ask Dr. MJ Why, because your health is important. Facebook Live, Instagram Live, YouTube Live broadcast that goes across the country. We are live in the studios here. We're here to answer your healthcare questions. We have a very special studio guest in the house tonight. I'm going to introduce in just a minute. But first, for those that were listening to the Ricky Smiley Morning Show, Wellness Wednesday this morning, we're going to talk about and continue our topic. Our topic is colorectal cancer. So March 26th is designated as National Colorectal Cancer Awareness Month, a time to raise awareness about colon cancer and the importance of screening for prevention and early diagnosis of colon cancer. So I thought a little Phil Collins would be appropriate music for us tonight. Colorectal cancer, the third most common cause of cancer in Black people. Number one is lung. Always lung cancer, even in individuals that don't smoke. Number two, prostate cancer in men, breast cancer in women. Number three, with a bullet, colon cancer, colorectal cancer. It is more common in African Americans than most other races, with a 17% higher chance of getting colon cancer than their Caucasian counterparts. In 2026, an estimated 160,000 new cases of colorectal cancer will be diagnosed in the United States, and this will result in over 55,000 deaths. So colorectal cancer is the number 3 cancer, but guess what? It's the number 2 cause of cancer-related deaths, and the rates are increasing. And guess what? They are increasing in the wrong demographic, adults under age 65, with nearly half of all new cases occurring in that age group. So prior to now, it was considered a disease of the seasoned. If you own Social Security, you retired, you're 65, then that's when you really would start being concerned about colon cancer. But now it's moving down. And we're going to ask our special guest to see if she can give us any insight into that. And our special guest this evening, Dr. Erin King-Mullins. She is a colorectal surgeon here in the city of Atlanta, trained at Emory University, and she's going to answer your question tonight. Good evening, Dr. King-Mullins.
Hello, good evening, Dr. Collier. Thank you so much for having me on in this very, very special month, Colorectal Cancer Awareness Month.
Well, we are so glad that you are here tonight. So with this, and your specialty, because one is very unique, it's a very unique specialty, period. And for a woman to not only be in that specialty, but to be thriving in that specialty. I mean, you are an outstanding a representative of the medical community, and you know your legacy is going to be amazing. But your day-to-day, all the things you do to save lives, to heal the sick with this special disease state, this special progress and process. And so we are glad to do that. So as a colorectal surgeon, most people are familiar with gastroenterologists. These are doctors that deal with the stomach and intestines and all that. So give some insight into the differences in those specialties, because there's a lot of crossover.
Yes, thank you so much for asking for that clarification, because I'll tell you honestly and truly, I didn't even know colorectal surgery was a specialty until after I started general surgery residency. And so when we talk about all of the various specialties within medicine, this is, I guess you would say, one of the newer specialties, but it is up and coming and booming, unfortunately, because of a lot of those stats you just mentioned. So the main difference between a gastroenterologist and a colorectal surgeon is just the nature by which the training comes. And so to become a colorectal surgeon, you have to do after medical school, you do a 5-year general surgery residency. And then after that, you do an additional 1 year of subspecialty training in the field of colorectal surgery. And to become a board certified colorectal surgeon, you actually must first become a board certified general surgeon. So that's the difference. It's just it's a surgical background. There is some overlap, but as you mentioned, gastroenterologists can treat the medical management of the overall digestive tract. They do the upper endoscopies, so they can look inside the esophagus and the stomach. They also do colonoscopies. We do colonoscopies, but gastroenterologists can manage like liver disease, pancreatic disease, all of those things. We do some medical management when it comes to the colon, inflammatory bowel disease, like Crohn's disease, ulcerative colitis, but colorectal surgery also entails doing the surgeries for colorectal cancer, hemorrhoids, but also a very, very unique topic that we deal with is pelvic floor dysfunction that typically affects women. And so women who suffer from incontinence or birthing injuries down to that area. So that's our unique field.
Wow. So since we start promoting that you were going to be on tonight, we know we got people from all over the country. So let's do our roll call and see who we have on the line. So give us your first name and where you're logging in from. We want to know who you are, and we want to salute you right now. Okay, Glenda Everett, good evening from Warner Roberts. Thank you, Glenda. We appreciate you. Glenda is a longtime follower. Crawford 54, hello. Thank you so much for tuning in. We appreciate you as well. Crawford, where you tuning in from? Okay, Candy Girl, MC. Hey, Doc, I have so much respect for you. When you talk, I listen. Very good. Candy Girl, where you tuning in from? And applause. Okay, and Tricia Reese, good evening from Austell, Georgia. And Tricia, you're a local girl. Thank you so much for being here this evening with me and Dr. King-Mullins. Okay, Lynn L. from St. Louis. Thank you so much, Lynn, for tuning in. Lynn has become a regular. We appreciate you for logging in, too. Okay, Miss Cali Girl. All right. Makila Bowling, how you doing from Douglasville? But Miss Cali Girl, I like that moniker. Good to see you. Sean Big Time Green. Now, Dr. King-Mullins, Sean Big Time from L.A. He's from Louisiana. He's one of my first males, and he has not missed an episode. So thank you, Sean, for being here.
I went to Xavier, so we got Louisiana.
There you go. Good evening, everybody. Taryn Ford. All right. Okay. Loretta McNair from Aiken, South Carolina. Hi, Loretta. Thank you for being here this evening on YouTube as well. Cindy Hill. Hello, Cindy. Thank you for being here. We appreciate you. From Fort Worth, Texas. There you go. We want to know. Okay, so we got North, we got South, East, West. Miss Cali Girl. Good evening, everyone. Dallas, Texas. We got Jazzy Jeff. Jazzy, I love that. There you go. Okay, Ms. V from Decatur, Georgia. Decatur, where it is greater. Okay, MZ Chocolate Bunny from Texas. I love that. Chocolate Bunny. Okay, Edward White from Raleigh, North Carolina. Okay, South. Who's in the North? Who's from New York, New Jersey? Who's from California? Let's go out west as well. Okay, J. Donnell Sr. from Florida. All right, J. Donnell. That's as far south as we can get. Edward Epps from the road. Edward is rolling out there. We appreciate you tuning in. Or just be safe out there while driving. Brenda Allen from Titusville, Florida. Thank you, Brenda, for tuning in as well. We appreciate you. Jennifer Lewis from Macon, Georgia. Hi, Jennifer. Thank you for tuning. We appreciate that. Got a lot of good questions today talking about colorectal cancer, and we're going to get to it right now. So good evening, B. Shingles from Jacksonville, Florida. Okay, there we go. So okay, Holly, we'll come back to it and do it again right now. Those questions are burning. So you see, Dr. King-Mullins, we got people from all over the United States that are listening and tuning in because they want to talk to you and find out about this disease state. So we're going to start taking the questions from the callers and see what it is they want to know about a colorectal cancer. If you have a family member, if you have been diagnosed, if you haven't been screened, then shame on you if you're 45 years or older and African American. The guidelines still say age 50 for non-African Americans, but let me tell you something. If you have any signs or symptoms at all because of what I just told you, the rates are going down. Dr. King-Mullins, why do you think that the ages of this disease state are dripping down now?
Yeah, so I'm actually going to give you a little bit of an update. We are actually now at 45 for everybody for colorectal cancer.
Oh, excellent.
Yep.
I did read that. As a matter of fact, that's exactly right. But
so we're 45 for everybody.
Everybody getting it at 45 now.
Yep. Unless you have a family history of colorectal cancer or colon polyps. And so I feel like one of the things that has impacted lower age is lack of clear understanding about who needs to get screened and when. And so since polyps, so the best way to think of polyps are like a mole, a growth that happens, and that's what eventually grows and turns into cancer. But because that is
inside the colon.
Inside the colon, yep.
Yeah.
So just like think about it, so just like think about if you have a mole on your face, right? And it starts growing and looking crazy and people are like, oh my goodness, you need to get that checked. That might be skin cancer. So a very similar process. That's how it starts inside your body. You just have no idea that it's going on. But because it's a pre-cancer, people need to know that a family history of polyps also indicates that you need to start getting tested earlier and more frequently. So if we're missing that, then people can be affected. But to get to your question about, why it's happening younger and younger, there are different factors. And one of the main things is I like to classify it as what you do eat and what you don't eat. So eating things
Processed
that,
foods.
yep, processed foods. So if you're opening a bunch of packages to consume your calories and your nutrition, if you're pulling up to fast food or just restaurants in general, right? Because who knows how many stops that food made before it made it to the restaurant, before they prepared it, and before it made it to your plate. And so highly processed foods, it is definitely a huge factor, but also not eating what you're supposed to, right? So, not eating a high fiber diet. So, lots of fruits and vegetables, maintaining more of a plant based diet, and limiting the meats and things like that you're consuming.
Okay, so now I know that most women
Mhm.
suffer from chronic constipation. One because of hormonal status, but most of it is social. They don't want to go to the bathroom and have a bowel movement outside of their own home. They will
Mhm.
hold it all day. And I tell my patients, I say, look, when you get the urge to go, you have to go. Because
Yep.
if you don't, I say the stool just get drier and harder and more difficult to pass. And then you're having to rely on laxatives on the weekend. So you're not having bowel movements during the week. You're doing laxatives on the weekend. And now you're just messing up the tone in the colon and making it very difficult for it to function appropriately. So give some advice to the ladies, because man will go anywhere. He'll pull over at the service station. He'll pull over on the expressway. He doesn't care. You know.
So yeah, I mean, and that's very true. And the top three things when people say they're not moving their bowels, right? Like number one, like water. And I just give this analogy: if you go to use the restroom and you try to flush that handle, and if there's no water in the tank, what happens? Doesn't go anywhere.
It
Okay,
just
so
sits
make
there.
sure you drink plenty of water. Water is going to flush things out. We mentioned eating your fruits and vegetables, but activity, especially after COVID, I started seeing so many more patients with constipation. How about you, Dr. Collier? Did you start notice that was you had a higher level of complaint about constipation? And that's that working from home, the remotely, the more sedentary
Exactly.
lifestyle, you know,
Exactly. When you're not up
it,
and moving about and
yep,
walking around, people staying at home, they're supposed to be working their Netflix and chilling. They got the computer on
yep,
and the Zoom call blocked out and they're not listening. And
yep.
so, so yeah, so you're absolutely correct right there. So a moderate level of activity, just keep moving. I can state unequivocally that if I take a walk after eating, I'm going to do much better than if I lay down on it, so to speak. So that's
Hmm.
going to be a problem and a challenge. So what are some of the change? People always say a change in your bowel habits. A change in your bowel habits is a red flag. So what are we talking about when we say a change in our bowel habits?
So if are typically a twice a day person, and now for an extended period of time, you're a once a day person. Um, and if there's a change in color, shape, you used to have a full formed bowel movement and now you're having pencil thin stools, things like that. And something that's persistent, right? Like if you just changed a medicine and then, or you got started on a new medication, those are reasons. Obviously, make sure that you speak with whomever prescribed that to understand if that is a side effect. But typically, we say a change in your bowel habits that lasts more than about 2 weeks. That's something new that's maybe persistent that might need to be investigated.
All right. So again, let's talk about the hottest topic going around. Everybody's on GLP-1s.
Hmm.
GLP-1s work by slowing the gut down. And so
Yes.
they delay gastric emptying, but I tell people the gastrointestinal tract is one long tube. Your mouth,
Hmm.
your esophagus, your stomach, your small intestines, large intestines, sigmoid, colon, rectum. The name changes to protect the innocent, but it's all one space. And
Right.
so if you slow down that space, and it's constantly in motion, it kind of moves like a snake when you see a snake
Hmm.
move. And when that's shut down or slowed down, everything slowed down except the reabsorption of fluid in the colon. That doesn't cut off. So you got stool and waste products that are moving much slower, but the dehydration mechanism is, if not nothing, it might be even fine tuned. It might be working better. So that makes the stool drier and harder and more difficult to pass under normal circumstances. So my patients on GLP-1s, I tell one to make sure they're taking probiotics. I recommend a cup of Greek style yogurt and or Activia brand on a daily basis. But I have a probiotic product for some people. They don't like yogurt. I had a patient tell me yesterday, it tastes like sour milk. I don't like that. Is there anything I can do? And I say, well, yeah, I have a product, my lipobiotics, that are available on the website that you can get that will help restore normal gut flora, so that bad bacteria, when it sits there and the stool delayed, and the excretion of the stool is delayed, that bad bacteria gets worse. It overgrows, and you can tell just by the nature of the smell, your stools become more foul. And when that happens, you know that the gut flora has turned, or now it's predominantly bad bacteria, so to speak. With probiotics, you get predominantly good bacteria, so it makes it more fragrant. Now, we're not saying you're going to be asking people come into the bathroom, wow, it smells like flowers in there. No, it's not flowers or strawberry ice cream, but it is not so bad that you want to close the bathroom for an hour before you let anybody else go in there. So those are some of the things that we have. But with GLP-1s, have you noticed any correlation with that and increased bowel symptoms, dysfunction, anything like that?
Oh, yes, definitely. And it impacts so many things, even when it comes down to preparing for a surgical procedure, because it slows down the forward motion of the food and digestion so badly that we've had to change our pre-op guidelines to make people hold those medications, like the injectables. They have to hold them like a week in advance, because there's a risk of what we call as aspiration. When you go to sleep from surgery, there's a risk of foodstuffs still being in the stomach, and people, vomit and aspirate. It gets into their lungs. It can interfere with the prep for your colonoscopy. You have to get cleaned out for us to be able to see inside adequately. And so that can prolong the time frame. Now, people hate, like, oh my God, I don't want to do the colonoscopy because I don't want to do that prep. Well, it might be even worse now. You may have to prep for 2 days instead of 1 day because your bowels have been slowed down significantly. I definitely like your recommendation on encouraging probiotics. And one of the other things that we also have started to recommend, I'm not sure if you do this as well, is chewing gum, which is considered sham feeding. So we kind of migrated that over from the recovery after intestinal surgery. Before they really started feeding people, they would say, hey, chew gum to kind of stir up the gastric juices. It kind of tricks your body to think it's about to eat. And so it'll start the digestive process. So that can also, sometimes something simple as just chewing gum can stimulate the intestines to start, functioning in the face of these GLP-1s.
Now, is that gum of choice, or are we talking specifically about sugarless, or it doesn't matter?
It doesn't really matter. It's just the mechanism of chewing and salivating and all of those things creates a downstream cascade for your digestive tract.
Okay, very good. So, Heidi, I know we got people that are asking questions in here. They're not coming across the boundary there. I'm not seeing any. Can you check that so we'll know, so we can respond to some of our listeners here? In the meantime, there we go. Is there a connection between GERD and colorectal cancer?
So, not necessarily directly, but there have been links to the fact that patients with GERD will traditionally have an abnormal balance of that good and bad bacteria. And we keep harping on good bacteria. So the function of the good bacteria, it helps break down fiber. So we talk about fiber, eating your fruits and vegetables. There's different types of fiber, but by and large, the good bacteria is actually what breaks down fiber into a product called butyric acid, which is literally the fuel, the nutrition directly for the colon cells to keep them happy. And so that's the importance of that. So patients who have GERD may have decreased levels of the good bacteria, and then some of the medicines that they take can also impact that. And then some of the medicines that led to them having GERD, like the NSAIDs, like the aspirins and the ibuprofens and things like that, also play a role in the colorectal risk and health.
Okay, so that's a good point to make, that sometimes the treatment can cause those symptoms. So that the H2 blockers and the proton pump inhibitors, those are the Pepsids, the famotidines, the Zantacs, and then we got the Nexiums and the Prilosec and all those things, because they alter the acid base, and that acid has a key function in digesting the food. And so if you got partially digested food, or food that's not digested as well, it's not broken down into its byproducts as we like for it to be, then when it gets into the gut, it ferments. It's just like if you were to put food into your garbage can and it's 98.6 degrees outside, And so it's going to be bad day one, but by the third day, before it's time for the garbage to be picked up, your garbage can starts to stink. And so you know that that's exactly what happens inside your body as well. One of the questions that I had this morning on the Ricky Smiley Morning Show was a woman that called in and she was saying, I have problems with my breath. I have bad breath. And so she had gone to the dentist. Dentist couldn't really find anything. And I shared with the listeners that more often than not, the problem is not with your teeth. It's not even in your mouth. It's because of bad bacteria in your gut that's coming up where it's not supposed to be. And now you're smelling it, you're tasting it. And guess what? So are the people around you and the people that you're kissing and that sort of thing. So you need to try to alter that gut GI flora, make it the good bacteria. I recommended that she get some probiotics, but I said in your situation, I would recommend the yogurt over the probiotics because they just kind of coat the stomach and help take care of the acid as well. I think that's a good starting place, and just to see where you are in a couple of weeks, see if that helps. And also, I say if you're blocked or backed up, you're not having regular bowel movements, you might need to do a cleanse, clean yourself out. Take a day or two over the weekend, take laxative, clean yourself out, and start from zero. Then take the probiotics and then a fiber product. I have the Lipo Cleanse, which is a fiber product. It is not a laxative, but it helps stimulate normal bowel movements as well. So anyone interested can go to the website right now, lipodrop.com, or you can do that on your phone while you're doing this, lipodrop.com, where we always have great situations going for people that are tuned into this broadcast. Okay, Linda Bloomer from Birmingham, Alabama. I was wondering, if I start taking Lipo Cleanse, can I still take my daily probiotics also? Linda, that's a great question. Absolutely. My belly fix is a combination of the Lipo Cleanse and the lipobiotics. Those two things together optimize your GI health, help decrease your bloating, and help give you that good bacteria predominant in your GI tract. It changes the gut biome in a positive way. And the cleanse keeps you moving. You have large, easy to pass stools that you would be markedly impressed by, because of whatever the size of your stool was before, you're gonna really be impressed now. You're gonna be like, wow, I really emptied out my colon. But and the point being, you don't want to keep that and carry it around inside of you, particularly if you're losing weight by the lipo drops, or you're on the GLP-1, or you're on some product and you're losing weight by whatever means. As you lose weight and the fat breaks down, the toxins that are in that fat are released and they're floating around, and they ultimately filtered by the kidney, by the liver, and they end up in your gut. And so you want to get rid of those. You don't want them to sit there festering. So that's where that my ultimate belly pack. You can go on the website, lipodrop.com, and you can read about Dr. Collier's belly pack and see what we're talking about. But again, it'll give you some great information about that disease state. Great question, Linda. Okay, user Wooz 5E. I'm not sure what that means. I've had headaches since 7/25. That's July of 25. So we're 9 months in. After an MRI and lumbar puncture, I was diagnosed with partial empty cell and prescribed topiramate 25. It didn't help. The dose was increased. I had a reaction. I stopped it. Okay, so now is a question of finding something. If you have increased pressure in the neural space, in the space where the fluid that floats, it keeps your brain, it's a cushion for your brain, but it also goes up and down your spinal cord. Sometimes that fluid, the flow of it can be interrupted and you get too much pressure in there. That's called hydrocephalus. And sometimes you have to decrease that pressure. There are medications that can do it, but if it's so great, I had a patient in my office today. She has a shunt in her brain that basically allows that fluid to just drain into her GI tract, and so it's metabolized easily and decompresses that space, so you don't have the headache. But you are in the middle of the workup, but don't let them dismiss you, because headache pain is not something you can see. They've done the big workup. You allow them to do an MRI and a lumbar puncture, and those basically did not make your diagnosis, nor did they fix the problem. So now you need to say, okay, now I need treatment that will address this. Anything you want to add to that?
Yes, I would say, obviously they're going to start by ruling out the most serious things first, and that's the importance of the MRI and the lumbar puncture. And now probably at the point of fine tuning that diagnosis and that treatment. So definitely stick with it. If you have not seen a neurosurgeon yet, I would definitely recommend seeing a neurosurgeon for evaluation for that as well.
Absolutely. So a neurologist, neurosurgeon, and don't take your primary care doctor out of the loop. Make sure the basic stuff is controlled. Like if you have high blood pressure, make sure your blood pressure is controlled and that you're taking care of that. Since this started acutely in July of 25, I'm presuming you did not have this problem prior to that, because you significantly and enthusiastically stated that is the starting period. So that being the case, we need to make sure that there was no trauma to the brain, things like car accidents or just bump your head. But it doesn't have to have been any of that. It could have had a disease process that just reached a certain level, and now it's manifesting itself as the headache is the primary symptom, and it needs to be evaluated. But with the MRI, they ruled out the biggie, the brain tumor. Everybody's concerned when you have a headache for any period of time. Everyone thinks they have a brain tumor. And so now that they haven't found that, what they haven't found is the answer. They've told you, like Dr. King-Mullins said, they rule out the bad stuff, but now they need to rule out the good stuff or the other stuff that can still be causing this problem, because they have not helped you. And oftentimes you get frustrated because of the process. You go and get these $1 million tests and nothing happens. It doesn't change anything. That's why when patients come to me and they ask for MRIs, they ask for them every day. And I explain to them an MRI is just a picture of the problem. I may already know what the problem is, and an MRI is just going to be a picture of what I already know. I say you're going to hurt before you go get the MRI. You're going to get the MRI, and then you're going to still be hurting, but your pocket will now also be challenged. So the point being that this technology, you can make diagnoses without technology, but sometimes you do need the technology. So I'm not anti-technology. Let's be clear. There are clear indications when it's time to get imaging, but you don't just get it, just because it's there and available, because you have that term in your vocabulary. I need a CT scan. I need an MRI. No, you don't. And I oftentimes tell my patients that. Okay, great question. Vanessa, this is for you. What is the risk of colorectal cancer if you have celiac? Do you need to get checked more often?
Not necessarily. Celiac disease, for those who don't know, is a gluten allergy. So the studies have not necessarily indicated that there's an increased risk due to celiac per se, but some of the overall dietary changes and things like that happen. I know, obviously with celiac, you are limited in the types of whole grains and things like that you can consume, some of those fiber products that you would naturally like to want to consume for good colon health. And so if you're not able to maintain that normal, well-balanced diet that we talk about, that we spoke about before, or if there's that imbalance of the good to bad gut bacteria that can impact, but there's not a significant increased risk, and you don't necessarily need to be checked more often.
Okay, great. Now, this opens the door to the discussion about gluten intolerance. I'm so tired of people being overdiagnosed with gluten intolerance. They talk to the doctor for 30 seconds, sometimes no more than 2 minutes, and they get diagnosed with gluten. I need a gluten-free diet. No,
or
you
IBS.
don't. IBS. So I call that the above I-20 diagnosis of gluten intolerance, because most people below I-20 don't have it, haven't heard of it, and don't have issues with it. So my point being that if we're considering that as a diagnosis, is that in your preview? Do you deal with gluten intolerance, or do you make that diagnosis?
I don't make that official diagnosis, but if I'm concerned about it, and so let's be clear as well, celiac disease is truly an allergy to gluten. Okay. So gluten is a protein that is found in wheat-based products. And so, our bodies can handle a certain level of certain things. For example, if you consume too much alcohol, it overwhelms the body's ability to break it down. You get drunk, right? And so the process for breaking down the gluten, if you overwhelm your system with it, everybody has different levels. And so, yes, you may have an intolerance if you're eating a big old Starbucks muffin for breakfast, and then you're having a Jimmy John's sandwich for lunch, and then now you're eating spaghetti for dinner. That is an overwhelming amount of gluten that your body may not be able to handle. So anybody may have a struggle with it. So there's different levels to it. But yeah, if someone is truly I'm concerned about it, I will then refer them to either a gastroenterologist or even an allergist, immunologist, if they have other concerning allergies or things like that I'm worried about.
Okay, one of the things I do in my practice, they have a blood allergy test. 1 drop of blood on a card. It's incredible, the technology there. And I use it for food and environmental. So, and most people have not had food allergy testing. And I tell them, this is not something you want to get back scratched on, because if you truly are allergic, you might have a bad reaction and and break out in hives from head to toe and all kind of stuff. I say, but the drop of blood gives you the same data and tests you for many more things. So a lot of people who thought they were allergic to milk because at their family reunion, they say, well, all the Colliers are allergic to milk, so we don't eat milk. I say, well, do you eat ice cream? Do you eat pizza? So you don't have a milk allergy. But nevertheless, that test will confirm that. The peanut allergies, it will confirm whether you actually have peanuts. And there sometimes you may be allergic to one type of nut. But when I tested myself, allergic to peanuts, but I could eat walnuts and cashews with no problem. So I really like that test. It tests for milk allergies, egg white and egg yolk. So some people, are allergic to one, not the other. Milk allergies. The number one appetizer in the world, shrimp, is checked. And most people eat shrimp all the time. And then, of course, if you get diagnosed as you're allergic to chicken. So shrimp and chicken makes people suicidal.
Well, yeah, and
I eat shrimp all the time. I eat chicken all the time. I say it doesn't mean you're going to break out and your lips are going to swell and you're going to have a full-blown allergic reaction. I say, but what you will notice is that you have an awareness of your gut after eating, and you should not. You have bloating, you have discomfort, you have dis-ease, you have something that's telling you something's not right. The food is just not digesting appropriately. And that may be because you have an allergy to that food. So it's easy enough to make the diagnosis. And I'm not minimizing. One, celiac disease and gluten intolerance are not the same thing.
Right.
Are they? Aren't they different things?
They are. Because celiac is the true allergy.
The patient that had the celiac disease, that's not what I was talking about. But what I'm talking about, people that get the diagnosis at the daycare center when the mothers get together and and they're saying, oh, well, if your child has gluten intolerant, mine is probably too, that sort of thing. You actually need to be tested and diagnosed in an appropriate manner. That means seeing your primary care doctor that's sensitized to that disease state, or your gastroenterologist. I wouldn't send anybody with that issue to you first. I would wait until afterwards. Okay, next question, Healy. Okay, Derek Thompson. I'm honestly scared of a colonoscopy. Is there any other way to get checked, or is that really the only option? Doctor, then I'll come in.
So this is one of my favorite questions because I feel like discussions aren't appropriately had about patients' fears, and sometimes they're minimized. And once we truly understand what the concern is, so I don't know if Derek can submit a follow-up about what specifically he's afraid of. But so there are other options. So I always say the number one screening test is the one that someone will get. Okay, so the colonoscopy.
You heard me say that this morning.
No,
so I'm just joking with you. No, but that's absolutely correct. So there's the FIT test, which is last on my list. There's the Cologuard, which actually has a high level of scrutiny. It's 98% accurate, but if it's negative, it can be a false negative. And so, and if it's positive, you got to get the colonoscopy anyway.
Yeah.
So, but if you've had a colonoscopy, particularly if you had one and you didn't have any polyps or anything, then intermittent screening with the Cologuard might be reasonable. But let's be clear, Dr. Collier stating and restating what you said. The gold standard is the colonoscopy.
Yes.
It's the test, and because this is the thing, if something is in there, they're already there to address it. If you got a polyp, they can take it out. If you get a positive FIT test, or if you get a positive Cologuard, that doesn't say you have polyps. It doesn't make a diagnosis. It just says something is wrong, something that needs to be further evaluated. So now you're a step away when you could have knocked it all out. So don't be shy about the colonoscopy. The clean out is the worst part. The day before the test, you're going to be asleep during probably anyway. I know I was fully sedated, but there are doctors that will twilight you, and that means you're not sleepy, but you're darn glad to be there. So it's not a negative experience from that perspective at all. So they definitely make sure that you're comfortable during the procedure. The colonoscopes, which used to be as thick as a water hose, are now about as thin as a pencil.
They're smaller than the poops. They're smaller than your poop that comes out.
Here. And they're very flexible, and they can drive, and so it's not, they're much smaller than what comes out. So it's much easier to get in there and do that. So not a test to be afraid of, Derek. Talk to your doctor. Make sure they make you comfortable first. It may be a discussion, show you some videos or something like that. But if not, like I said, just decide I'm going to do what I need to do to optimize my health. And that means getting a colon screening, because if you don't get screened, you can't get diagnosed. You get a late diagnosis, you're going to have a bad outcome. Colon cancer is 90+% curable if you make the diagnosis early.
It's also preventable if you get the
and
colonoscopy.
preventable,
Just
but
like you
nobody
said,
gets
you can
the
actually
diagnosis
stop
early.
it from
wait.
happening if you get rid of that polyp. But then, and to your point also, not everybody is a candidate for Cologuard. Only so if you have not had appropriate family discussions about if there is a family history of colorectal polyps or cancer, you actually are not a candidate for Cologuard. Cologuard and fit tests and all of those things are for average risk individuals without any symptoms and no other risk factors.
So if you look down and you see you got pigmented skin, you African American descent, you are higher risk than anybody else on the planet. So so just being black puts you, that's a risk factor. And so if you smoke, if you have a family history, so by the time you get the family history, you 2 or 3 risk factors, you've already checked those boxes. So it's very important to just make it a part of your, I'm going to be healthy when I'm 45 now. But of course, if you got a family history of, I got a patient right now, Dr. King-Mullins, who's has a family member, first degree relative, a parent that was diagnosed with colon cancer. They told everybody to go get checked in the family, and this person is I think 38, something like that.
Mm-hmm.
And they've been ignoring it for over a year. Told them to go get checked, and because it was a familial type, and they just are afraid to do it. And I said, we had a long conversation, a come to Jesus meet, and I'm hoping that they're going to go get it. They have yet to, but I'm hoping that they do. Okay, great question, Dad. We appreciate you for opening the door. Reggie Davis, I keep hearing colon cancer affects the Black community more. Why is that actually happening? Dr. King-Mullins.
So there are environmental factors. African Americans are more likely to live in places that have certain environmental hazards if they're living closer to certain manufacturing plants. If their
Garbage
soil can be
dumps.
contaminated, also diets, right? Diets that are high in processed foods and red meats and things like that. And then just kind of lack of awareness and knowledge. Like the studies have shown that one of the number one reasons that patients, especially African-American patients, don't get a colonoscopy is because no one ever told them. Or, the family is not talking about those risk factors. Everybody is, very hush hush. And this is something that directly impacts, like if you knew that your child just got a brand new car and they driving down the street and they're about to go up on one of the most dangerous intersections that there is, you're going to sit them down and tell them how and what to do or whatever. Same thing. Like if you have something in your body that can impact your brother, your sister, your child, we have to have these conversations because they directly impact someone else's life. So you can't be secretive about what these medical diagnoses are that are running in the family.
So in the culture, nobody wants to get that cancer diagnosis and share it with, they don't even want to share it with family. Sometimes they don't share it with spouse. So right. This is a cultural phenomenon that we have to get past. Now, the phenomenon you were speaking about earlier is called epigenetics. And that's where your environment impacts your health. And so if you're living in a food desert, if there's no grocery stores with high quality foods in there, and you buy a lot of your groceries from Stop and Cops and little corner grocery stores and gas station grocery stores, etc., then the quality of the food, the types of foods, the thing, let's put it this way, don't ever buy anything off the roller that's been sitting there for 8 or 10 hours and it's 2 for 99 cents. Okay, what do you think you're getting then? Now, it doesn't even look edible, much less appear edible. So those types of foods are not the food choices that you need to make. So crunchy fruits and vegetables, fresh fruits that look healthy are the ones that you need to add to your diet. And again, I am a big proponent of yogurt. I love yogurt, but I don't just take it by itself. I take the cranberry nut mixture and put that inside my yogurt. And this morning I had fresh fruits. I had strawberries and blueberries that went into my yogurt. And that's my breakfast. And that coats my stomach. It helps with a variety of different things, but it gives me that good GI flora. And so I'm hoping that Dr. Collier's breath is not too repulsive. People not backing away from me. Okay. Thank you, Reggie. That was a great question. Okay. Anna Harris from Richmond, Texas. Do you believe in your lifetime there will be a cure for colorectal cancer? Doctor.
So unfortunately, no, because I think with what's going on in the world right now and inflation, it's going to be very difficult, I think, for people to unfortunately purchase some of the things that we would recommend that they purchase to eat. But hopefully, I'm hopeful. I'm prayerful. I'm just a little bit skeptical in my lifetime. I might be a little bit older than you. I mean, younger than you think I am. But but yeah. So
Well, one of the things that I like to say is that one, cancer treatments have come such a long way. It is now standard operating procedures. When you have a cancer diagnosis, that you get a team that includes a spiritual advisor, a nutritionist, a primary care doctor, a surgeon, a radiation oncologist, and a person and a heme oncologist. So it's not just one doctor, or you're not going to one doctor and 2 weeks later seeing another doctor who hasn't spoken to the first doctor. So there's a disconnect between your therapy and your treatment options. And then genetic analysis of the cancer has been a major breakthrough. And so they can determine the type of cancer, what it will respond to in reference to chemotherapy, because traditional chemotherapy is hoop skirt, meaning they cover everything. So they just throw the poison at everything and hope that it has a positive effect on the cancer without doing too much damage to you. And so they have now fine-tuned a lot of chemotherapies, and they have smart bombs that literally don't do any damage to your tissues. They can actually create from your own blood cells targeted white blood cells that will only kill cancer cells. And so this is technology that exists. But guess what? It's not technology that usually is made available to you. One, because it's very expensive. And there are literally insurance companies that require a doctor not to tell you about it. So you may not know. So I tell people, if you have a cancer diagnosis of any type, you have to be your own advocate and your own, you have to do the research, get somebody else to help you with it. If you're not good on the computer, get a young person in your life, a niece, a nephew, a cousin, somebody who knows how to find this information so you can get the real deal and find out what your real treatment options are versus the treatment options that are presented to you. It is no secret that people with various types of insurance or people with money who not insurance is not an issue and cost is not an issue, get various types of treatments than people who have no insurance or on limited insurances or insurances that compromise. This is the reality of medicine as a business. But the problem is, if you're your own advocate and you fuss enough to ask for and demand that you're treated optimally and with the best therapies that are available, tell me, doctor, what are the other things I can do? Don't just let them say, oh, we're going to give you, chemotherapy and radiation and then send you on your way. Because I see that happen all the time. And I have to advocate for my patients and say, no, I'm aware of this therapy. Have you done this? And I've sent people, so stop going there and go here, go from one center to another. And so a lot of centers, they will, particularly when you're coming from another center, they really feel the need to outdo the previous center. So they'll give you more and treat you better.
Second opinion.
All the time.
No.
And we got, great cancer centers. We got the Renthorpe that's associated with Emory. We got the Cancer Treatment Centers of America now that also have the genetic testing. That one of the commercial comes on all day, so you can hear about those things. And then Piedmont has one now too. And Emory has the Winthrop, and then
we have, and let me just take a step back real quick. The term cure is a loaded word, right? And it's a process. When someone's been diagnosed with cancer, someone is not determined cured until they are 5 years without any evidence of disease. And so there's a whole, so if someone gets diagnosed and then they get treated and then it comes back within a couple of years, so it has to be gone, demonstrated to be gone and no evidence of cancer for at least 5 years before it's deemed a cure. And there's a lot of standardized regimens now, but as you said, the genetic testing of the tumors are very different. There's some particulars, if it's a hereditary form or what we call as a wild type or a de novo form, meaning, in someone who doesn't have a family history and it's a new diagnosis within that family. But the importance of this whole conversation is the fact that we can prevent colorectal cancer. It is one of the most preventable cancers there is.
It's the most preventable out of all of them. Well, I wish they had a colonoscopy for pancreatic cancer, but they don't. Most of the time, people diagnosed with pancreatic cancer, they're already stage 4, and they're on a limited lifespan. But with colorectal cancer, with routine screens, the amount of disease that is prevented, so not talking about curing, it's much better to prevent than cure. Okay, so, but also take your vitamin D at 5,000 international units per day, and that will help improve the inflammation, which is it's the baseline for most cancer and most disease processes. Diabetes is an inflammatory process. Hypertension is an inflammatory process, and so is high cholesterol. So those three things, the metabolic syndrome, result in the deaths of most African Americans. Black people die from heart attacks and strokes. So I'm going to control those things. You're not going to have that. So guess what's the next on the list? The cancer diagnosis. So that's why we have to do the screenings and optimize your health. Good question, Anna. Lou Newsom. I want to know how to rid inflammation in the stomach and cloning and colon. I think he meant colon. If he's talking about cloning, that's a whole nother thing. So, doctor?
Yes, and so we've mentioned it a few times this evening, talking about the good and bad bacteria. So probiotics, eating the healthy fuel for the colon. So a diet that is high in fresh fruits and vegetables that are unadulterated, limiting processed foods. All of those things can help decrease inflammation in the body. No smoking, minimal alcohol consumption, and then being active. So
now, wait a minute, Dr. Collier didn't say about alcohol.
hold up now. At your own risk. But there's two sides of the coin when we talk about obesity versus lack of activity, and both of them each have been indicated to increase risk and can increase inflammation in the body. So if you are not active, getting that blood flow going and moving, then you have higher levels of inflammation in your body. But also if you're overweight and what we call is the central obesity, so people who have that gut, that belly, those fat cells, they are actually secrete inflammatory like hormones, and they can serve as estrogens and various things in your body. So that in and of itself, even apart and separate from lack of activity, can create an inflammatory process within your body.
All right, so let's talk about the inflammatory infections in the intestinal tract, colitis, ileitis. These new biologics are amazing in reference to the relief that they can give to a disease that was previously really, you treat it with high dose steroids, and then people gain weight and had diabetes when they normally wouldn't have been diabetic. And so now, what do you think about the Embros of the world and every other commercial on television now has? You have colitis now, you can go skiing, you can go hiking, and not have to worry about running to the bathroom and all those.
Hey, listen, some of that stuff is putting colorectal surgeons out of a job because, and not be, being a little bit facetious. Same thing can be said about some of these GLP-1s and bariatric surgeons. I know there's a lot of, that's a hot topic of discussion. But yes, so these immunomodulators. So inflammatory bowel disease is basically like a form of an autoimmune disease. So people may have heard of lupus or multiple sclerosis, rheumatoid arthritis. Something has triggered the body to fight different cells within their body. So the inflammatory bowel disease, so your immune system is fighting your gut. And so these biologic therapies, the Remicades, the Humiras, and all of those things are regulating the immune system to get it to calm down and not fight itself. And there's a lot of expanding diagnoses for this, with psoriatic arthritis, or even a special entity if anybody is battling, because it's definitely in increased levels within the African-American population. It's called hidradenitis suppurativa, when you have it's an inflammatory process of certain
under your arms right here.
Yep, under the arms, in the groin, around the anal area, women underneath the breast folds. That's now also being treated with these biologics. And so there's something environmental going on that's triggering these higher levels of autoimmune style diseases that are being treated with these biologics.
So in the gut in particular, to answer your question, Lou, one, the probiotics, either probiotic capsules, tablets, or naturally from yogurt. And the Greek style yogurt has the highest amount of probiotics. And if you want a brand name, the Activia brand is also very good from that perspective. Then vitamin D, the body's natural anti-inflammatory, and omega-3 fish oils. Now, I had a question this morning. If you're allergic to fish, can you take omega-3 fish oil? Sometimes you can, sometimes you can't. There are people that are allergic to shellfish, but they could eat cod and tuna and salmon. So, but to avoid that as an issue, a flaxseed oil is a very good omega-3 oil that is not fish-based. So that is one that you can take, and there are at least 3 other alternatives. Flaxseed oil is just one that I highly recommend. And so those are natural things. Dr. Collier has 3 things that I recommend that everybody on this planet should do every day. And those are Dr. Collier's 3 for optimal health. And that's vitamin D, omega-3 fish oil and probiotics. I take them every day, and I can assure you your health will benefit by taking Dr. Collier's Optimum Trio. So go to the website, lifodrops.com right now. You see we got a 15% off code hidden in the video descriptions. So you can go there and pick up those things to help optimize your health, decrease inflammation, not just in your stomach and your gut, but throughout your body, your joints, the joints that are inflamed and causing you to have arthritis, the inflammatory processes that lead to heart attacks and strokes. All of those things can be improved, minimized by taking those supplements. And those are supplements. They're not medications, and each and every one is compatible with any disease state. So you can have everything wrong with you or nothing wrong with you. And these are perfectly safe, and they're compatible with virtually any prescription medication that you can have too. So not a problem from that perspective. People always ask that question. Well, I'm diabetic. Can I take this? And you're the person that should be taking it. I have high cholesterol. Or will this interfere with my cholesterol medication? Omega-3 fish oil not only helps lower the cholesterol, it increases the HDL, the high density lipoprotein, the good cholesterol. It lowers the LDL, the low density lipoprotein, the bad cholesterol, and it lowers your triglyceride. It actually gives you better benefit than the prescription medication. But it's not either or. I tell people, I'm not saying don't take the prescription. You take your prescription medication, and a supplement is just as the word states. It's a supplement. It is in addition to, not instead of. Great question. All right. Dr. Beverly Carterimi, I love that. Should you refrain from eating the foods that give you a lot of gas? I have gas from everything except bread. And you slim and trim too. And I'm so glad you're not one of those I don't eat bread people, because Dr. Collier
I mean, I would actually recommend, if you're not already, just as Dr. Collier has been mentioning quite a bit this evening, about the probiotics, because again, it may be the abnormal digestion. And the other thing that we haven't actually mentioned this evening, digestive enzymes. Those are very important, because as we age, the different organs in our body may not function as well. And so your pancreas, while you may not have diabetes, but especially if you have ever been termed as being pre-diabetic, your pancreas makes several different types of hormones. And so insulin is used to help break down the blood sugar, but there's other digestive enzymes that help you break down your proteins, your fats, and all of those things. And so if there's anything irregular, off kilter, you may be lacking some digestive enzymes. So my recommendation is actually to keep a food diary. So write down specifically what you're eating, and when you're getting those symptoms in relationship to what you're eating. And that can help you understand certain types of foods that are causing those symptoms, and understanding where within your digestive process things may be off kilter based upon when are you getting those symptoms immediately after you eat, or is it an hour later, a couple hours later, things like that.
Okay, so yeah, and I highly recommend that you see your provider and ask for a food allergy blood test, a blood food allergy test, not the back scratching. And that will help with the diagnosis. Sometimes, again, just that you're backed up. Clean out will always help. They used to have these places where you could go get a colon cleanse, and they would literally clean your colon from head to toe. They were everywhere. Now there are a few that still exist. And so what do you think about that? The colon cleanses where they literally irrigate your colon.
I mean, I think that is an option. It's not my go-to, because again, what you're doing is you're really just irrigating out. You're just washing out. You're just rinsing out the colon, but you're not necessarily providing any specific nutrients or anything like that. And again, if we do that too constantly, that's more of it's like a manual scrub. So you might be washing out some of that good bacteria that might be in there. So I always say it's best to cleanse from above, but if you're feeling particularly uncomfortable, those are options, but you also have to make sure that you're not suffering from a bowel obstruction. Okay. So, me as the colorectal surgeon, I'm going to jump to worst case scenario. And so if you're someone who is struggling to have bowel movements, you're really bloated, you've had abdominal surgeries before in women, that even means C-sections, right? Or hysterectomy. All of those things, I wouldn't just blindly go get a colonic until you really understand what's going on, because if you're having a blockage or something, you can actually make things worse and injure yourself.
Good advice, doctor. I had a patient this week that has had 15 surgeries, abdominal surgery. She's had 5 children, and had fibroids. And so they operated on the fibroid, did a myomectomy.
Mm-hmm.
Okay. And so they came back, she had another myomectomy. Then she had scarring from the previous surgeries that entangled her intestines. So she's ultimately ended up with 15 significant surgeries, as she's called it. That's not counting colonoscopies and other tests. Finally, they did hysterectomy on her after, basically destroying everything else, but by that process. And so, but now, she's not obstructed, but she has, her complaint to me today was that she's losing weight. And so that's a red flag, of course, when you're not
Mm-hmm.
trying to lose weight. And she's eating everything, but no change in her appetite, no change in her bowel function, anything. She's just losing weight. And so that requires she's been seen by the gastroenterologist, had the upper endoscopy, the lower endoscopy, and the capsule where you swallow with the camera in it. She's had that workup and everything was negative. So I told her that just means we haven't found the problem yet and we need to look further. So don't get compromised by a negative test and you still having symptoms. That means something is not right. So but that is exactly what you just described. The problem was a bowel obstruction, and caused by scarring from previous surgeries in her. Okay, next question. My mom just recently had her first colonoscopy at age 68. I thought she'd had one in the past, but didn't. Should she continue to get them at this stage, and if so, how often? Doctor, current recommendations.
So number one, it's going to depend on those results and the family history as well. That still plays a role once you even started getting colonoscopies. So if polyps were found and removed, the number, size, type, and what they look like on the microscope will indicate whether, if it needs to be done more often or more frequently. And then also, like I said, family history. So if there's any family history of colon cancer or polyps in the family, she should be on a 5-year schedule. Now, I know the guidelines indicate that the average individual, there's not necessarily a requirement for continued screening after the age of 75. But again, if there are risk factors in the family, and when someone reaches 75 or 80, and I got some young looking 75 and 80-year-olds that I still anticipate will be hanging out with me for the next 10, 15 years. So if they are at increased risk for forming cancer, I would advocate them to still get colonoscopies if it's medically safe for them for preventive purposes if we know they are at increased risk. So I'm sorry, I know I may not have answered your question directly, but it really does depend, number one, on the findings of that colonoscopy and family history.
So it sounds like there needs to be a conversation made with the doctor that did the colonoscopy. They normally will give you a recommendation. Normal colon follow-up in 10 years, one polyp follow-up in 5 years, 10 polyps follow-up in 3 years, or something of that nature. Should have been some guidelines or some guidance given, and there may have been, but mom was just coming out of anesthesia. She couldn't remember, and when she came to you, she said, well, they didn't tell me anything, and they actually told her a lot. So, so the communication factor is high. Now, remember, your mother's 68 and still an adult, and the doctor is not required to talk to you and has to have her permission to do so. If that conversation is going to be held. Oftentimes when you do that, it's not a problem. But again, they can't just send you the results, so to speak, without your mother agreeing to doing that, because a lot of times children of adults will try to infantilize them and flip the nature of the relationship to now I'm the adult and you're the child, and they treat a grown person like a child in the doctor's office. And I'll just say, please I ask them the question, let them answer unless they're incapable of doing so. Then that's different. But, sounds like mom, is alert, functioning, and doing just well. But I say this once again, if you're African-American, you're at high risk. So if you got the first one at 68, just do them based on the guidelines that they gave you, but not doing another one because they say, oh, you're 68, you don't need another one now, because the guidelines say that after this age group, you shouldn't have to get another one. Well, no, just had a patient.
And my other answer to that is get them as often as your insurance company will pay for it. Okay.
Yeah.
Some insurance companies will, no matter what your risk factors are and how many you had before and what those results were, some of them will pay for a screening colonoscopy every 5 years. So when you show up in that Starbucks line every year on your birthday to get your free Starbucks because you a member, show up every 5 years, however often the insurance that you pay for will cover your screenings. And that's actually my recommendation.
All right. Final question, Holly, and then we're going to close it out. Okay. What's the best pills to use for lymphatic drainage for kidney? Okay, well, one, lymphatic drainage is throughout the body, and the lymph comes back to your central circulation, and then it is drained by the kidney. So there's not a direct plumbing connection there. But if there's an issue with lymphatic draining, that is really a challenge. Particularly, you see people with legs swollen from the ankles to the thighs. This can be treated most of the time with some kind of wrap or pressure or something that puts negative pressure to push that fluid back into the circulation. But if you don't maintain that, it'll come right back because of the primary pathophysiology of the reason that you have lymphatic drainage. And so there are physical therapist companies now that specialize in lymphatic therapy and treating of that. And I refer my patients to that and get great results from that until they stop following up. Now, when they were doing breast cancer, removing everybody's breasts and lymph nodes, women would always have that lymphedema in one arm, the arm on the side they had the breast removed. So you don't see that anymore. It's very rare and very unusual because the surgical technique has been improved and they don't do the type of things they used to do when they were taking everything out without considering the consequences of that surgery and the post-op follow-up. Now, but if we have peripheral edema, that's usually in the legs, but can be in the upper extremities as well, particularly edemas associated with obesity, because you got the fat cells putting pressure, squeezing the fluids out of the vasculature into the peripheral tissues. And so it's a complicated phenomenon when you're treating lymphedema. There's no one answer for that. Oftentimes, patients will just be placed on diuretics, which doesn't fix the problem, sometimes makes it worse because you're taking more fluid out of the vasculature and less fluid out of the tissues. Just because you empty the fluid in the veins doesn't mean it's going to allow the veins to take more of the fluid back in. It doesn't happen that way. So that's a complicated process. And unfortunately, I have not seen an effective cure. I've seen treatments that can control, but I have not seen a cure for this. Have you, Doc?
Yeah, I mean, and a lot of it really just depends on where specifically the lymphatic drainage disruption is. And so if it's in the extremities, activity and like you mentioned, physical therapy and wraps play a role. Some of it may be nutritional components if you're, if someone is very, very malnourished and they have low protein levels in the body, if they have liver disease, they're cirrhotic. I mean, there's so many complexities to it that it really does have to be handled on a case-by-case basis.
Okay, that was our final question. I want to thank you, Dr. Erin King-Mullins, for being here with us this evening. Erin, you are wonderful. Thank you so much. We're going to have you back to talk about this timely topic and to let everybody get to know who you are and what your service. You're in the Atlanta area. Tell everybody how you can be reached.
So our website is colowellness.com. That is COLO wellness.com. And the phone number to the office is 770-325-2275. And I'm on all the socials as Dr. Tushy Touchup.
I love that. Say that again.
Dr. Tushy Touchup. Yeah, we'll have to come back one day and talk about that.
Oh, absolutely. That is the greatest social media name of all time, Dr. Tushy Touchup. So very good. I am Dr. MJ Collier, available on all social media at AskDrMJ. Sign up for the YouTube channel right now. It doesn't cost you anything, but there's hundreds of videos on various healthcare topics, and you can get your medical ready reference. So listen, you are now indoctrinated. You are our medical missionaries. Dr. King-Mullins and I are challenging you to share this information that you have heard tonight. Next time you're sitting around, you're playing cards, you're watching the game, you're in a family gathering, talk about your family's medical history. Don't just say grandmama had some type of cancer, I don't know what, but it was everywhere. It was all over her body when she died. Find out a few more specifics about that disease state. And if you have a disease state, share that with your family members. Let them know what they need to be concerned about or things they need to be checked for. It can just be high blood pressure. It can just be diabetes. But a cancer diagnosis, you are almost obligated to share that information so people can get screened and early testing. So I hereby salute you, my medical missionaries. Get out there in the world and go share this information. And remember, you can reach me on all social media, Ask Dr. MJ. You can listen to me on the Ricky Smiley Morning Show, Wellness Wednesdays, and you can also DM me, and I promise you, I'll get back to you. Thank you so much for tuning in. We appreciate you. Dr. Erin Mullins, thank you so much for being here. Anything else you want to say?
You.
All right, very good. Applause, applause. Thank you, Helix. We appreciate you.